And then we started empowering the patient. So the other way we didn't reinvent the wheel is Hill Physicians actually sent us some little posters to put in the rooms on how to do a blood pressure correctly. And most of the people at UCSF throw anything away that doesn't say UCSF on it if we didn't invent it ourselves. But I said, this is really good. Let's just put this up like we were told to do. And we did. And it's right above the patient's head. So when they're checking the blood pressure, the MA is actually seeing that, and the patients actually can look up at it and make sure that it's being done correctly. So they check the technique. So I think both embedding learners and empowering patients to make sure things are done correctly is huge. Everywhere you go at UCSF, there's a sign that says, it's okay to ask me if I washed my hands. All right, so it's actually okay to ask if they're doing their blood pressure correctly. I think we can learn a lot from the hand washing QI initiatives. So what's the role of the patient in all of this? Well, so we talked about quality control and feedback. There's a lot of people talking about patient empowerment here. I think owning your number, it's your blood pressure, not mine. So you need to know what it is and what it should be. I think where we haven't done well in cardiology and medicine in general is open communication about side effects. We shame patients a lot, and so we don't give them an avenue to be forthright with us about whether they're taking their meds and what they do and don't like about it. And then when their blood pressure's still high after taking a med, what do? We add another med, and then we add another one, and pretty soon they're on 5 drugs. But we don't really say, that didn't work for you, let's ditch it and try something else. And so there is something called an N of 1 trial, which is just a fancy word for try it out, and if it doesn't fit, try on something else. And I think that might also help us engage our patients and get their interest in being able to talk with us about side effects. So this is, I see someone from the AHA here. This is from the Go Red for Women campaign website of the AHA. Know your numbers. I think it's just a really powerful statement, and I hope that it really gets embraced widely. But really, patients ought to know what their blood pressure is and what their blood pressure goal is. And just as much as they know anything else about themselves, like where they keep their car insurance in their car. It's actually that important. So we need to, I'm actually thinking we should probably put this message up. Don't leave clinic unless you know what your blood pressure is. It's on all these after visit summaries, but I think we need to highlight that. So barriers for patients, it's pretty much, as we all know, asymptomatic condition, easily forgotten. The meds sometimes make you feel worse, not better. They don't have any ability to measure it at home. They don't feel like the doctors really care about it because we're not demonstrating that we care with the same kind of assiduous technique that we ought to be. It's a low priority item, often is what patients tell me when they come to their visits. It's really expensive to park and come to the doctor and take time off of work for an asymptomatic condition. And then they don't have surrogate measures of efficacy. So you don't have symptoms to follow from your stick blood glucose. Somebody in the back said give everybody a home monitor. Most of our patients don't have one, even if they can afford it. And even if they can afford it, they don't know what to buy, and we don't really have a good spiel on what to tell them to get. So lots of problems with that, and they don't see the results, the fruits of their labor. So what are some solutions? Well, it can't be just sending doctors dashboards of hundreds of patients that aren't at control. There's got to be a workflow solution, okay? It can't just fall on the shoulders of people doing after-hours, non-billable work. And so what is the role of the team? So a lot of people mentioned team-based care. So that's kind of how I got to know Marilyn, this paper came out in the American College of Cardiology JACC journal, and really talking about the role of the clinical pharmacist in cardiovascular care and in cardiology clinics in particular. And really in terms of delivering patient-specific services, but also facility-specific services. So what are you doing with your EMR integration? How are you putting your preference list together? Who's going to be the steward of your formulary? Who's going to provide QI? And then what can you do at a policy level? And how can pharmacists play a role in this? So I think that's also going to be really critical for us moving forward. And this is something that we talk about a lot, I'm sure all of you talk about, is how can everybody work at the top of their training level, doing what they know how to do best. And this is going to be even more important, as we all know, in light of the SPRINT trial, which was released last year. Over 9,000 patients randomized, non-diabetic patients randomized to intensive versus standard treatment, so less than 120 systolic versus less than 140. And the trial stopped early due to massive benefit, okay? In a very hard endpoint, as cardiologists think of, 27% lower composite endpoint, heart attack, stroke, acute coronary syndrome, heart failure, or death, and then 25% lower hazard of mortality. So this is another throwdown to our entire field in the middle of when we're trying to just get the basics correct, and then this trial comes along. And we've all kind of known and people have felt that we should be doing intensive care in a lot of our patients, but this will be incorporated into guidelines for sure. And we need to be prepared for it, and all the more reason that we're gonna need a team, because it is really hard to sprint, and it takes a really long time. So Marilyn and I have embarked on a pilot study where we are trying to actually define not only your GNC8 goal in our patients, but also a physician optimal goal tailored for your patient, many of which is less than 120, and it's very hard to do. And even in the sprint trial, they had a hard time doing it. Not all those patients got to less than 120. And then you gotta get there and not kill the patient or have them faint, pass out, throw up from your medications, and afford all this stuff. So this is a big throwdown that we need to be ready, and I think this is why we need to do it.
That does look like a gun job.
Track Town USA.
Same goal. So UCSF Hipster, this is a little project that we started. It's very small, but I hope to grow it, and I'm kind of interested to get everyone's feedback later on in the discussion part of this session. But hipsters, if anyone, who knows what a hipster is?
All the young people.
All the young people. If you've been to San Francisco, it's someone who, well, I'm not going to define it, but why don't you come out and visit? And there's a bunch of them near our clinic. So, and in fact, there's a whole new, instead of a parking lot where our patients can park, they built a hipster fire pit where you could make s'mores and drink beer in the middle of the day, and wear interesting sunglasses and have a handlebar mustache. So that's pretty much what a hipster is in San Francisco. But what a hipster is for me is hypertension innovating personalized strategies for excellent results. And so it's my own kind of throwdown to those in our clinic to say, how can we do personalized medicine? I mean, it's enough about genomics and genetics, proteomics, and all of the other things we talk about when we talk about personalized medicine. But this is really personalized medicine. How can we tailor care for our patients, pick a goal for them, and work with them hand in hand to get them to where they need to be? And so high-touch care from a cardiology team, really intense patient engagement, and how can we engage our staff to get to these goals? So I think in order to do this, we're going to need lots of different strategies, and we have all kinds of patients and challenges. But I wanted to spend a moment talking about mobile health and digital health because I think we can't ignore it. And I put a quote up here from Eric Topol, who is a cardiologist down at Scripps, but also pretty well known as a digital health kind of guru these days. And he wrote a book last year, and this is what he said. We are embarking on a time when each individual will have all their own medical data and computing power to process it in the context of their own world. This will set up a tectonic power shift, putting the individual at center stage. What have been dubbed the 6 most powerful words in the English language, the doctor will see you now, will no longer be true. And the title of his book is The Patient Will See You Now. So we can talk later about how you realize this vision in disparate patient populations, some of which don't have as much access to care as others. But I think this is coming, and we need to be ready for it. And actually, we need to embrace it, because the only way we can do this work is if the patient is helping us. So mobile health or mHealth, how is this going to help us? Closer monitoring. We can think about that faster time to control, the door to blood pressure control time. We can intervene more rapidly with side effects and have a very self-aware patient who understands their triggers. I just had a guy who was doing this, who was taking blood pressures at home and sent me the whole log, and they were all horrible. And there was one day when he was 110, in the middle of everything being 150, and he's a cardiac patient. And before we changed his meds around, we said, what happened that day? Why was that a good day for you? He said, oh, well, that was my birthday. And I spent time with my family and I wasn't working. And so we just spent some time saying, how can we make more days like your birthday? So at that time we didn't really change his drugs, but he started doing yoga and exercising and spending more time with his family and less time at work. And he just messaged me saying that his pressures are much better and he has more days that are like his birthday. So I think patient self-awareness of their own life has been something that's huge. I don't feel that I'm very well prepared for this, honestly, from my training to do all the kind of motivational interviewing and lifestyle education as a cardiologist that I ought to be, and maybe I can learn from people who are in primary care who know more about this, but I think we're gonna have to train our fellows on how to do this better. This is way more convenient for patients and frees up the clinic, and it allows you to kind of experiment, and this is where the fun of medicine is. Try this out, see if it works, let me know. That's part of the joy of medicine, I think. But then when you start going out there and you look on the shelf at the Walgreens and you see how many different types of cuffs there are, and you start opening up the journals, and every day there's a new article about a texting intervention or this intervention, or give them the Omron or the Whitings or this cuff, it really gets pretty overwhelming. So I think Marilyn said, just do it. Is that what your quote was? So I think, yeah, just do it. I mean, try something, okay? Something is better than nothing, as long as we do no harm. And so what we did is we decided to try a pilot trial with a company that's literally blocks from our clinic in San Francisco, a startup company. And this is Vital Labs. We have Rebecca, Dr. Felice from Vital Labs, who's joined us here. And Marilyn's going to spend a lot more time kind of talking about the pharmacist side of what it is to manage patients remotely. But we've embarked upon a 120 patient pilot where we give patients a blood pressure cuff. We prescribe it for them, and we have someone come into the clinic